Hello, Health Psych students. This is part 2 of social support. And I know we were having some tech issues with the recording, so hopefully you have watched those links at this point in time. And we were talking about the longevity project. So now let's move on and talk about how might social support be beneficial to our mental and our physical health. We know that we've already talked about social support bolstering the immune system. And remember that we talked about in the stress lecture that about 15% of our bodily energy is in our immune system. And we want that humming along at a nice 15%. And so these people who are feeling isolated or rejected, their immune system is not nearly as strong. It makes them more susceptible to getting illness. We know that being around other people, there have been studies that just show it lowers blood pressure. We know that things like touch, like a hug or hand holding, helps lower blood pressure and lower stress. The fibrinolysis stuff is blood clotting. And people have less blood clotting when they feel connected to other people. We know that endocrine health, there are negative loops and positive endocrine loops, hums along more smoothly when individuals feel connected with others. We know through brain imaging that some of those natural opioid receptors in the brain, which are responsible for why people can get addicted to opioid medications, are activated. So people are getting reward, people are getting soothing when they are feeling connected with others. We know that being around other people helps release dopamine, the neurotransmitter substance, again, that gives us a sense of reward. And we know being around other people releases oxytocin, and oxytocin is the love hormone. After mammals or women birth a baby, they get a tremendous flood of oxytocin. And that is the hormone that helps them to bond with their babies. There's even research, I found it really interesting, where they take dog owners and they either inject the dog with a placebo or they inject the dog with oxytocin. And then they let the owner and the dog interact, and then they have the owner rate their level of happiness. And they have found that if your dog got injected with oxytocin, that dog's going to be feeling more loving. And then the owner is going to feel more receptive to that loving. And that's going to make the owner happier. So even across species, oxytocin is the love hormone. Oxytocin is also, this is kind of on the side, is released when people make love and after they've had orgasm. And again, that's that kind of bonding of like, oh, we're good together. I want to be together with you again in the future, that type of thing. So the love hormone. The downside to social relationships, of course, this is going to be very intuitive for a lot of you. If there's social strain, I know a lot of, just as an example right now, a lot of healthcare providers who are on the front lines dealing with patients with COVID-19 are feeling a lot of social strain. They're doing a lot of giving, and they're not getting time to themselves. They're not getting enough time for rest. They're not having fun time. They're not laughing. They are just really strained. The caretaking piece to it, particularly for people that get, I call it sandwiched. And sandwich would be where you are caretaking for elderly, your parents or in-laws or that type of thing, and you're caretaking for children. And then that also could be described as role overload, particularly if you are totally caretaking and you're giving. It feels good to give, but if all you're doing is giving and you're not getting back, that's going to be a downside. It's going to be stressful for people. Certainly being in conflictual relationships where there's a lot of negativity going back and forth, taking it even further where there's fear involved that somebody is going to verbally assault you, physically assault you, sexually assault you, is going to be very bad for one's health. And we tend to see when people are in those conflictual relationships, more problematic medical health, more cardiovascular disease, more pain, more weight gain and obesity, and even slower wound healing. If you remember back to the New Medicine documentary, Janice Keogh Glazer and her husband I can't remember his first name, Glazer. They remember the wound healing study where they had the caregivers of Alzheimer's patients, and then they had people of comparable demographics that weren't caregiving, and they gave the specific wound, and that the wound healed much faster in the non-caregivers, and it healed much slower in the caregivers, probably because caregivers have down-regulated immune system, and their wounds are not healing nearly as quickly. And then imagine, people going into surgery, how big those wounds are, how important social support could be for somebody who is undergoing surgery. We know that people who have been rejected have more inflammation in their bodies, which is going to drive poor mental health, is going to drive disease processes, making them more susceptible to cardiovascular disease, making them more susceptible to pain, making them more susceptible to cancers. Poor sleep being first line of defense for that. Remember that healing that we talked about in the stress and coping lecture. And then more unhealthy coping behaviors, so more like binge eating, smoking, not getting enough exercise, that stuff. And then remember back in the Walsh article and at the beginning of the semester, we talked about religious and spiritual involvement, contribution and service, that a lot of individuals find community in their churches, their temple, synagogue, that type of thing. A lot of individuals who are following the shelter at home are really missing that connection right now. And then I even know down the road from me, there's a church that is still meeting on Sundays, and they're still meeting inside. And I keep waiting for a potential outbreak happening here in our community because of that. But anyways, these things can be very valuable for people's health. Okay, let's switch gears a little bit now, and let's talk a little bit about pet research. And I'm featuring some of my pets with this little program that I found that put wigs on them that I thought was hilarious at the time. 58% of people have a pet, only 35% have children. Pets tend to be very popular in our culture. I don't know if y'all been keeping up, but during COVID-19, there have been a lot more individuals who have been adopting pets who did not necessarily have pets, so that they have companionship in their homes. People with pets have better mental and physical health. But then I want us to kind of think about that the pets help fuel positive health, but you have to have a certain level of health to be able to caretake for a pet too. So there's a little bit of the cyclical. People who have pets have less medical office visits because of their better health. And this is part of the reason why we have pet therapy programs, where in a lot of hospitals or nursing homes, pets are allowed so that patients can be interacting with them. And oftentimes those are kitty cats or those are dogs, but there is even research where they will allow horses and people to have equine therapy. People recover faster after a myocardial infarction, after a normal heart attack, if they have pets. And the proximal effects are even better than a best friend. And for a lot of people, that is because their relationship with a pet gets closer to unconditional love than human relationships can be. I feel very strongly that the closest that we get to that in human relationships is parent to child. But even if you have unconditional love for a child, there's still going to be times where they do things where you might not like them so much. But with pets, it's a little bit more of that unconditional love. Particularly with dogs, you show up at the door and they you've been out of the house to go get the mail for 4 minutes, and you show back up at the door and they're like, "Oh my gosh, you've been gone. I love you. I miss you." Cats, they can be aloof, but they can also be very loving. Oh, and for cats in particular, the purring, if you're petting a cat and it's purring, the vibration of a purring cat is very meditational. And you might not necessarily get that with a dog, but cats offer up that meditative, kind of that physiological effect from the purring and the vibration. So we can sort of ask, why are pets so good for us? This is Monty. This is the cat that he found us as a kitten, and he was skinny and he had worms and he was starving. And we asked around the neighborhood if he belonged to anybody. He didn't. And he is the cat that he was a kitten and we heard him outside. And then the next day I drove in my SUV out to Ashe County when my parents lived out there. We get out of the vehicle in Ashe County, so about an hour away. We get out of the vehicle and we hear meowing, and we open up the hood of the engine, and he's sitting on the battery. This kitten traveled all the way out to Ashe County from Valley Cruces. And then it was like, well, he found us and he's ours. But anyways, my sons staged these pictures one time. So Monty does a lot of drinking. He spends way too much time on Facebook, and he's greedy. He likes money. And then we've got Mr. Leo, my big shepherd down there. So pets give us companionship. They give us something to care about. They can be a lot of fun. Again, my boys stage and Monty with these pictures is like, this is hilarious. They are a sense of constancy. It is always nice to be able to come home if you've got your pets there waiting for you. Certainly they can give a sense of safety. I assume we're talking more about dogs here than fish or kitty cats. And I definitely know that when I'm out with my dog, when I'm running or I'm walking him or I go hike alone, I feel very, very safe. Like if anybody tried to do something to me, he would be definitely very protective. They can, particularly dogs, help humans exercise. And then there's the whole tactile connection, the petting and the hugging. And again, oxytocin gets released in the animal, oxytocin gets released in us. That purring kitty, those kinds of things can be really valuable. And a lot of people, just as an example, even sleep with their pets and allow their pets in their bed. So my sons made me a Pokemon card of Monty, whose formal name is Mr. Bunklesworth. And I found this hilarious. He is the sweetest cat in the world. And he even sees you across the room and he starts purring, but he is not very smart. And so the IQ drop as his, weapon. He'll do this thing, like he'll want inside and we let him inside. And then like a second later, he'll want outside, and he like, you could stand at the door all day long and he'd go in and out. He's just not too bright, but sweet. Very, very sweet. Okay, so now we're moving on to clinical listening skills. So now we're back to kind of talking about humans. And I do want you to kind of recall in the new medicine, remember in the training, they were testing the med students, and you had the med student who was very rusty and wasn't very good and said, "I'm sorry, you're crying." And then you saw the other med students who were very skilled. You saw the attending physician taking the med students and the residents around on the rounds, and how he did a really nice job of having them take turns getting at eye level with the patient in the bed, how to ask questions, how to be very empathetic with the patient. So I do want you remembering stuff from the new medicine. Okay, so when we talk about processing information, this is going to seem very intuitive, but it's a little bit harder than it sounds. So we are receiving a message from a patient or a client. They are talking to us and they're telling us about their lives or their symptoms or what's going wrong with them. We're taking that information and we are processing it. So we're listening and we're hearing it and we're understanding, but then we have to figure out what message do we want to send back? Like, what do I say now that is going to gather more information, or what do I say now that is going to be helpful to this person? If it's a traditional psychotherapy hour is 50 minutes. I find it fascinating how, even if I don't have to look at a watch or see a clock when I'm working with clients, I know 50 minutes now from doing a lot of private practice. Here's how I want to explain this. I had a former student, Darcy Wallace, and Darcy came into our graduate program, our master's program in clinical. And in her undergraduate major, she had double majored in French, and she was proficient at French. And she is starting to see her volunteer clients and her clients, and she's videotaping them. And she's learning how to do this, what we're talking about right now. And she shared with me an analogy one day that I thought was really good, so I want to share it with you. She said that early on when she was learning French, when she would be speaking with somebody who was speaking French to her, she would have to take that message in French. She would have to convert it into English in her head, think about it, decide what she wanted to say back to this person, convert it from English into French, and then say it. And she said that early on in learning this new language, it took a tremendous amount of cognitive energy for her to communicate back and forth with somebody in French, until she had practiced it so much, and that she had like got so proficient with French in her head where she said she could finally think in French. She didn't have to translate into English. She could just think in French. And so talk back and forth with somebody, French, 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 and no need to translate inside her head. She said that is what learning about communicating counseling feels like for her, that it took so much thought processes and so much work early on in her training until she got proficient enough. And I feel like, yeah, I'm definitely there. Like when I'm talking with the client, I am fully there with them, and I don't feel like I'm having to think hard anymore. It's just become more natural. And again, I say this because this sounds a little more complicated than it is, and it really takes some practice to get these skills down. So client stories, this is going to apply a little more to psychotherapy, but it also could apply to medical patients also. That oftentimes by time people come in for medical help or they come in for therapy help, they've got a whole story that is the impetus for why they're there, that they want to tell you. And it's a good idea for us to give them time to tell that story. We get a lot out of it. We get a lot of content information. As clients tell their story, we get an idea of what their thought patterns are like. So that could be really helpful for cognitive therapy. We're getting a feel for how much are they emotional versus how much are they intellectual, or do they have a nice blend of that. And if you were to do non-directive therapy, so something like psychoanalytic or psychodynamic therapy, this goes on and on and on in those types of therapies. In more modern day, like CBT or ACT therapies, we let this go on for a while until we have a real good picture of a person, and then we ask them questions to get a good feel for their whole mind, body, self. But then we get more directive. We start doing interventions. We start having them focus on their cognition, awareness of their thoughts, and either diffuse like an ACT or cognitive restructuring in CBT. But I want to go back to telling the story piece to it. This is James Pennebaker's work. And Pennebaker found that, and through a whole series of studies, he's written books about this, that when people go through a traumatic experience or they go through a really stressful experience, that it can be very therapeutic for them to write about that experience. And the typical study they would do, he'd have people write about that event for 20 minutes, at least 4 days in a row. And he would encourage them, the best instructions he ever gave, and he manipulated a bunch of this in research, is I want you to focus on the content and your emotional responses. So focus on the emotions and the facts about that very stressful event. And one of the things that he found over time is that early on in the writing, and this makes sense, the same thing happens when you speak about a traumatic event and you're doing exposure therapies on that. The event is very emotional and all over the place initially in the writing. So lots of emotion words. It's oftentimes not linear in time. And then by day 4, this really interesting natural thing tends to happen in people, that they move from the venting and the all over, oh my gosh, this thing was horrible, it was horrible. They get into more problem solving, and they get more specific about, is this like physical problem solving I need to do, relational problem solving I need to do I realize I have no control over this, the classic serenity prayer, and I need to just focus on emotion focused coping. But you get after day 4, it moves from a lot of emotion words to a lot of action verbs. And so it's a nice way of like telling the story over and over again. It's almost an exposure technique, but it moves people into problem solving as opposed to just being stuck with that stress or stuck with that problematic event. So I use writing very frequently with my clients. I do it myself. I don't do it on a regular basis because I really don't have enough to process. But when I'm going through some really stressful times in my life, I pick back up the writing and do that journaling because I find it to be very, very therapeutic for myself. And I have seen it be very therapeutic with my clients. And so, okay, so there's a lot going on when we're hearing those stories. This is a psychodynamic term, and it's called developing a holding environment. And there's little Leo when he was only like 7 pounds, when he was a baby, and I had just taken a nap with him, and he was still waking up, and I just thought this was such a cute little, like, what a peaceful little scenario after his little puppy nap. So the holding environment, ideally, we are creating this safe space, whether we're a medical healthcare provider or we're a psychotherapist, that we're creating this space where people are allowed to deal with their stuff. And so even an example of like if a person starts crying, they usually say, I'm sorry. And a lot of times we will, very gently handle over the tissues and say, I'm here with you. This is obviously touched a nerve or something like that, or I'm here with you. This is the place where people come to cry. Or no need to apologize. I'm glad you feel comfortable enough feeling this intense emotion sitting with me. I had a client at one point in time. I knew she had a sexual assault history, and but when I first asked her and inquired about that stuff in her background, she's like, "I do, but I'm not ready to deal with that right now." She had other more pressing things in the her current life that she wanted to deal with. And after we dealt with those kinds of things, I brought back up, are we ever going to be able to go back and talk about that horrible thing that happened to you? And she told me, she's like, I'm afraid if I get into it that I am going to fall apart and I won't be able to stop crying. I won't be able to stop heaving, and I will be on the floor of your office, and like Humpty Dumpty, I will not, I'll fall apart and I'll never be able to be put back together again. And I remember telling her that in this holding environment, it's like, it's okay if that happens to you. That's my job. It's my job to help put you back together again and help you get past these traumatic memories and what happened to you. And after we kind of established that, she was like, okay, I'm willing to start this therapeutic process. So we want to be fully present and mindful. And here I'm going to talk about 4 different non-directive listening responses that get people deeper into their disclosure, deeper into what's going on. The first one is clarification. And this is when you ask a question to better understand detail or understanding, just kind of clarifying, like, tell me more, or what did you mean by that? Clarify word meanings. My sons joke with me because I use the term hooking up wrong, although I've read the book Hooking Up, and I realize that even college students have differing definitions for it, that sometimes hooking up is getting together and just making out with somebody. Sometimes hooking up is getting together and having intercourse or having oral sex. But my sons still tease me because I would do things like, well, my girlfriends, we get together on the weekends and we go, we hook up and we go riding, which would involve spandex and bicycles and that kind of thing. And I use it as meaning like we get together. So my sons are like, oh, Mom, that's not what that word means. Anyways, if, like, let's say if we clarify and we're getting it wrong, clients they'll correct you because they want you to be understood. So if I had a client in front of me, a young person who says, well, I hook up and then I feel bad about myself, I'd say, well, what do you mean by that? What's going on when you tell me that you are hooking up at a party, that type of thing. Paraphrase is when we just reflect back or send back the cognitive or the factual information that a client has told us. So it might be like, wow, it sounds like your coursework is really stressing you out this semester, and it's about the coursework. And they're like, oh yeah, I've got the hardest classes I've ever had, that kind of thing. We've got to be careful not to sound like a parrot where they're like, yeah, math is stressful. And we're like, oh, your math is stressful. Yeah, my math class, it's really stressful. Oh, we got to be careful that that's not what we want to get into. So we're only using the paraphrase to let people know that we're listening, or we want to elicit more discussion about what they've told us. Reflection, on the other hand, is when we are sending back affect or emotion. And we're doing this because we want clients to express their feelings. Sometimes we want them to experience their feelings more intensely and get in touch with what that is. So I used the example of handing tissues a minute ago, but a lot of times what we do, if a client starts crying, that means they're moving into the very emotional, distressing content. And what we do with the tissues there is just simply hand over tissues and just sit and just wait. Let them cry, let them experience that emotion. Maybe they've needed to confront the emotion and feel it. And it's not until you feel it that you're able to move past it. a lot of times we want to help people become aware of their dominating feelings. We oftentimes want to help people discriminate accurately among their feelings. One of the classic things that we see, and again, I'm not being sexist, I'm not meaning to stereotype, but a classic kind of thing that we see is when boys and men are hurt or upset or they're feeling rejected, it oftentimes comes out in anger and aggression at others. And so anger is one of those emotions where a lot of times we want to take when people are feeling angry and help them deconstruct that. What is really going on? Because a lot of times it's not that somebody has affronted them and the interpersonal anger is called for. It is usually that people are expressing anger when they're really feeling some other things that they ideally get in touch with and address. Summarization is when we tie two or more themes together, or we identify a common theme or a common pattern. An example would be helping a person realize that, let's say they're engaging in rigid thinking and they're having interpersonal problems with this person and they're having interpersonal problems with this person. Maybe it's not that people are just being difficult for them to get along with. Maybe the rigid thinking is spewing out interpersonal behavior in them that is creating problems in their relationships. And would it be okay to address the rigid thinking as an example? Sometimes we summarize to just, if people are kind of rambling and they're getting it out somewhere in their disclosure and their discussion where it's not being productive. So we might summarize and go, hey, let's review where we've been today. And let's see if we can kind of pull this all together. Interpretation, this is a little bit more of a psychodynamic type of thing, but every now and then we do this in the more modern CBT and ACT, is where we're taking and using patterns of behavior to better understand oneself a little bit more, or looking at somebody's unconscious motivations. I'll give you an example. I had a young woman client years ago who had a baby out of wedlock, and she and boyfriend had since ended their relationship. It didn't stick, and she had this belief that every child deserves a mother and every child deserves a father. And so I would hear about what was going on. She would contact ex-boyfriend, invite him to come and be with baby or toddler at the time I was seeing her. And then she'd get really, really frustrated with what would go down. Like he didn't know how to play with the kid. He wasn't very nurturing. He would get easily frustrated or angered. And so she would get frustrated, like, why are you acting, like you do it like this, you're doing it wrong, that kind of thing. She never got to a place where she trusted this man being alone with her child. And anyway, she would keep coming to see me, and she would just express this frustration over and over and over again of like, oh, he's not doing it right. And I don't think he's bonding, and the kid's not getting anything out of this kind of thing. And it was all because she had that very strong belief of every child deserves a father. And so I finally one day had to address this and say, oh my gosh, you keep pulling this man into your life, and you keep pulling this man into the child's life because you believe a child deserves to have a mother and a father. But all I'm hearing is frustration. And I'm not hearing that this is a very valuable relationship for you. I'm not hearing that this is a very valuable relationship for the child. I'm not hearing that this dad is valuing this relationship. What I'm hearing is you saying every child deserves a father in their life, but does this child deserve this father? Meaning, is this of true value to your child? And she was able to kind of take that interpretation and realize that really what she was doing was inviting this man into her family life, and it was creating only stress. There was no good coming out of it. And she was finally able to kind of let him go and let him fade away. And she was the best mom she could be to her kid. So some barriers to listening, therapists that are too frenetic and too hyper. And I'm not in the classroom with you all, but if I were in the classroom with you all, I think you would realize I'm a pretty high energy person. And when I teach in classroom, I like to move around a lot, that type of thing. But I can tell you, I am not that way when I'm working with my clients. I'm not like in there with my clients, like, oh, that kind of thing. I can calm myself and I can kind of come down to their level. We need to be careful if healthcare professionals are too self-centered. One place that we sometimes see this to be problematic is, let's say you have a history of addiction and you have recovered and you're working with people with substance dependency issues. A lot of those therapists in their training have to get past that the path that they took in their own recovery may work for some of the clients that they're serving, but there are a lot of different ways that people heal from addiction and heal from dependency, and be open to the fact that your particular path may not be the path that you need to make sure everybody else is trying to do. We need to be careful that we are not getting too preachy, or not like, la, 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 you got to do this, 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 you got to do this. Sometimes we need to back up and we need to listen. One of the things that I have found in training our graduate students, and they've even, they joke with me over time, is a lot of times young graduate clinicians work so hard. They want to help people and they want to fix people. And a lot of times they don't know how to pause and be quiet and let their clients think. Let them think in the moment and let them express themselves in the moment. So in training with my graduate students, I will oftentimes say, okay, quiet, ball, put the ball in your client's court. And then at times when they're doing role plays, they'll pick on me and play with me, and they'll be like, la, 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 la. You know, like just sort of physically demonstrating. It's like, I've said something and I'm putting the ball in your court, and I'm just going to kind of sit and listen and let you do some of that work. Clients do so much better when they come up with their own behavior change strategies cognitively. They're going to do so much better if they've come up with the idea of what to do about their problems than if we tell them, here's what you need to do about those problems. Because if I tell you, here's what you need to do about those problems, if it works, then it was my great idea. If it doesn't work, and sometimes it doesn't, guess what? If it doesn't work, it's my fault. So you've got to help clients own it. And a good way to help a client own it is you lead them into coming up with their own problem solving. And sometimes that requires just some time and some patience in that back and forth conversation to let them do the thinking. And then therapists or healthcare providers who are just too self-absorbed. I worked in a practice at one point in time where there were very thin walls between me and the therapist next door. And the therapist next door, I found it interesting, had a hard time keeping clients. Like, she would get clients referred to her, but they would terminate pretty early. And she would get frustrated with like, oh, they're resistant and they're not ready for change. And maybe they'll come back when they're ready, that type of thing. But I found it very interesting sitting in the office with the thin walls. When a client would go into her office, I would just hear the therapist the whole time. I couldn't hear what she was saying, but I could tell it was her voice. She would just talk and talk and talk and talk and talk, and there just didn't seem to be any client talking. And I remember it after, kind of making that observation of like, wow, she talks a lot. I wonder if she ever lets her clients, if she ever listens. And then I put two and two together. It's like, man, maybe that's why she's not keeping her clients, because they don't feel like they're heard and they don't feel like they're listened to. So motivational interviewing, we will spend more time talking about this throughout the semester. And when we get to the tobacco use and smoking lecture, I'll spend a lot more time. We're going to actually watch some video clips about motivational interviewing. Motivational interviewing was developed by Miller and Rolnick, and they were people that worked a lot in addictions. And one of the things that I can definitely say, motivational interviewing is the absolute opposite of a confrontation. So confrontation would be, you're an addict until you admit that you're an addict, you're never going to get better. Motivational interviewing would be very different, the opposite of confrontation. So we do a lot of asking and inviting ourselves into conversation. Keep in mind, this stuff not only works with clients and patients, this stuff works really well in your personal relationships. So remember this, like if you've got a sensitive topic, like let's say you and your significant other have been fighting a lot about finances, or fighting a lot about parenting kids, that type of thing. Instead of going, we need to talk, that usually does not start out, usually that's when significant other like, we need to talk, and significant other's like, oh crap, this is going to be bad. Broaching it of like, hey, is there a time today or tomorrow or this weekend where we can sit down and talk about our budget and our finances? Or is there a time where we could sit down and talk a little bit about the kids and what the kids are going through while we're all trapped in this house in the pandemic? So we invite people into conversation, and that makes them feel like there's been an invitation and they have choice, which feels so much better to have somebody say, hey, can we talk about this sensitive topic together? So much better than we need to talk. Mind if I ask type of thing, like mind if I ask about your sensitive topic, mind if I ask about your sexual history or something like that. We do things like, so what's stress like with you? I know all humans have stress at times. Tell me what it's like for you. Is it okay if we chat a little bit about how you cope with this stress? That might be a really good question. Let's say somebody's been referred to you with an addiction or alcoholism, that type of thing. That might be inviting them to talk about stress. And then let's say they say, well, now that I think about it, the way I get out of my head and I stop thinking about ruminating and all the stress that I'm experiencing in my life right now, I guess I drink. It's like, okay, tell me, does the drinking help? And then if you keep like going down that path, what you will oftentimes get is this, like, yeah, it helps in the evening. It helps me get out of my head and stop thinking, but then I feel so lousy the next day, or I've got family members that are complaining about it. It's creating conflict. And then it's like, okay, now we're really talking about the problem. I love this is the ball in the court. Like, let's say you've been talking with the client and all about this kind of stuff. I love the ball in the next court and go, okay, so where does this leave you now? And let them think, because a lot of times there has been forward movement in their recovery or their healing. And so where does this leave them now helps them reflect on that. So let's say, like, after that conversation with the stress and the drinking, so where does this leave you now? The person might be, you know what? I really like my drinking and I really like how that feels, but I guess I hadn't really thought about how in the long run, it's kind of making things worse. Or I really hadn't thought about when my family was complaining, I just thought they were nagging. I never really thought about the fact that they may be hurting. See how you've moved things along. This has been really good. Okay. Also, with motivational interviewing, it is a way, again, of entering in. Use this in your personal life. It is a way of entering in very sensitive material with somebody that, imagine if you've got a particular topic that oftentimes blows up. Or what happens for a lot of couples is when they fight, they usually return to the same themes all the time. And so you oftentimes will ask, well, what does it return to? Well, anytime we fight, whether it starts about the toothpaste or how the toilet paper is put on the roll, or whether it starts about like who's going to do the chores, it always comes down to, I do more work around the household. I do more parenting than you do. And that other person's like, no, you don't. I do more of that stuff. If you have these common themes. It is a beautiful way of honoring client autonomy. So instead of being like in their face, that type of thing, it acknowledges that you are a human being. You are the expert of you. And because you are the expert of you, I'm just going to help kind of ask questions in a way that you can take your inner knowledge, your inner expertise of yourself, your strengths, and help you use that stuff to help you move forward in recovery or treatment. So it's already said it's the opposite of confrontation. I was trained, and I've used this. If you get out of a client or patient or significant other, whatever, a yes, but as soon as you get a yes, but, it's sort of like I'm saying yes to pretend that I agree with you, but obviously I don't feel that way. I don't like your perspective. And so a yes, but is as a person has gone on the defensive. And as soon as that person has gone on the defensive, you have lost that relationship with them. You have lost that conversation. And I was trained that that is the responsibility of the therapist, that if you get a yes, but out of your client, you are not using your MI, your motivational interviewing, the right way. And one of the things that I was trained in, and we train our clinical graduate students in, is we will watch videotape of them in therapy sessions. And at times what we will do is we will watch the tape without sound, and we will totally just watch the nonverbals. And like, let's say the therapist was doing MI, and the patient's in there and they're talking, and then all of a sudden you see the patient go, and their nonverbal shift, that's a yes, but that's where you've lost them. And so there can be some really good training that happens in that. And then another thing that motivational interviewing does, and this is really valuable for any healthcare provider, is, remember in stages of change, we talked about how it looks linear, but it's not really linear, that some clients, take a couple steps forward and sometimes they slip back a little bit and they move forward a little bit more. It acknowledges that even a client's motivation to heal, recover, grow, whatever, is going to be fluctuating. And it is natural for people to feel ambivalent. So like, let's say in the last session, you had a client, real thoughtful, like, oh yeah, I really need to consider my drinking. And then they come in the next week and you ask about the drinking. Did you have any sober nights? Did you cut back on your drinking? And they're like, no, I've been drinking the same. It would be really easy for the therapist to get angry, to feel something like, why didn't you last week you told me you were going to think about this and do something about it, and you didn't. Knowing, if we know that's natural, like that fluctuation and that ambivalence is absolutely natural, then we need to, it's called roll with it. We need to roll with it. So it would be something like, I'm curious, because last week when we ended the session, you had made these connections between your drinking and your relationships. You'd made these connections with your drinking and your mood and not feeling good and all this kind of stuff. And now I'm hearing you say you haven't changed anything about your drinking. It sounds like you're feeling kind of ambivalent about this whole recovery process. You want to talk about that a little more? Let's talk about that ambivalence. Okay. Some other things that we do in motivational interviewing, and I felt like there were some examples back in the New Medicine video where we did not see this modeled real well for us. And I can give you an example. One of my memories is the young woman, med student resident, was talking with the gentleman in the bed. She said something like, you don't drink or smoke, do you? And the pressure when you say you don't drink or smoke, do you, is for a person, even if they do drink or smoke, to be like, well, you obviously you disapprove of it, so I'm going to say no. A better way of saying is, tell me about your alcohol drinking behavior. And if the person doesn't drink, they'll be like, oh, I don't drink alcohol. If you say, can you tell me a little bit about your alcohol drinking behavior? And if that person does, you've invited them into conversation about that. So tell me, is this like every now and then? Is this on a nightly basis? Or do you drink during the day? That kind of thing. So we do a lot of open-ended questions. So you don't want to ask people necessarily yes, no, unless you're just asking about a physical symptom, like, does your throat hurt? Yes or no. You don't have to say, tell me about your throat, that kind of thing. So a good way of kind of getting at maladaptive coping would be, tell me good ways you feel like you handle stress, and tell me some ways that you feel like you're a little rusty, or some ways that maybe you don't handle stress very well. And you're going to get a lot more out of that than saying, you don't drink or smoke, do you? That type of thing. Lots and lots and lots of reflective listening, lots and lots of relaying back emotions and empathy. So let's say you've got that person of like, I go and take Percocet when my spouse has been yelling at me. And the empathy part of that would be, you'd be like, oh, that's bad. Or you could be like, wow, it sounds like when your spouse is yelling at you, that is really hard for you to take, that is really painful. It's like, can you tell me what that emotion is? Can we get in touch with that? Because it sounds like you experienced that emotion before you reach out and take the Percocets. So lots and lots of empathy. And I can tell you that feels, on the receiving end of that, that feels really good for a patient or a client. It's like they are willing to understand me. They are willing to get in my shoes. They are willing to know what I'm going through and how I feel. And then summarization, affirmation. Again, I love that. So where does this leave us now? And then before we start giving advice, it is even a nice thing of, am I asking, do they want that advice? So I'm just going to read this bottom one to you. So I'm hearing you say that losing weight's been really a real struggle in the past. It's like that for a lot of people. I've worked with a lot of people who've been told by their doctor they should lose weight, and they find it to be really hard. Would you like to discuss some strategies that have helped people to lose weight? Because I've got some strategies that I've seen successful before. So you invite them into that and then be like, so you've acknowledged, yeah, it's hard, it is. But then you're also saying, hey, I've got some ideas. Would you like to hear them? Again, this works great with family members, friends, significant others. Yeah. Okay, so now we're moving on to nonverbal behavior. And so you take a look at this picture, and I just want you to think about what kind of relationship they have. And I think most of you would look at this and say, you see happiness, you see closeness, you see caring, they're touching hands. So there's obviously a certain amount of intimacy and empathy with it. And so now we're going to talk a little bit about this. And I've told you about how in training, a lot of times we will watch tape of healthcare provider or trainee will watch tape without sound to just focus on the nonverbals. There's also times in training where you actually will have therapists transcribe and just pay attention to the words that go back and forth without actually seeing the visual and without actually hearing the voices. And it's a nice way in training of kind of breaking these things apart and practicing the different levels. Because again, when we're given social support, when we are communicating in healthcare, we are saying words, we are showing nonverbals, we are reading them, we are here. There's a lot going on in the processing. So breaking it apart in the training can be really helpful. I don't know if my little face is in front of this picture here, but you take a look at this picture and you probably get not a feeling of comfort and joy. You probably get a feeling of anger, right? That he's angry. I'm going to pick on Obama a little bit later too. So Fritz Perls was a psychologist who said everything that a patient does obviously conceals an expression of self. And so we want to pay attention to, in the people that we're communicating with, if we get a different feel for a word versus an emotion, we want to acknowledge that disconnect. There's something going on there. I'll give you an example. So years ago, I stopped snowboarding after I had a hip that finally had to have a surgical repair. But I would snowboard, not very well, but I would snowboard. And when my son was little, he was skiing at the time before we picked up snowboarding. We were coming down a hill at one point in time. He's way ahead of me because he would go much faster. And I witnessed him, took a terrible spill. Skis were helicoptering up in the air. And when I finally got back down to him, he had dug his helmet. Like he had fallen so hard into the snow that he actually had grass and turf. So he had snow and grass and turf in his helmet. And I get down to Christian and I get down on his level and I'm like, Christian, are you okay? And he goes, yes. And so I'm getting this disconnect. He's saying, yes, he's okay, because that's what a tough little boy's supposed to say. But he wasn't okay, right? And he's shaking his head. He's like, yes. And I was like, do you want to go in and get some hot chocolate? Okay. And so let's take a break and, after this spill. So an example of even a kid given a different verbal, nonverbal. Ooh, what's going on here? Okay, so let's take a look at Tiger Woods here, and what message are you getting? And he was in a golf match at that point in time, and he's actually telling the crowd to be quiet. But we also know from some of Tiger Woods' history, he had some skeletons in his closet. And so there's a little bit sometimes of like, shh, I don't want to talk about that because there's a secret or there's a lie. Clients, the people that we're talking to are a lot more aware of the words, but they're not oftentimes as aware of their nonverbal behavior and what they're expressing and playing. Some people have a better poker face than others, but a lot of people do not have a very good poker face. I do not play poker. I'd be terrible at it. I'd be like, hey, Ricardo, I would not be able to control my face. And so anyways, we want to pay attention to our clients' nonverbals. Kinesics, I don't want to go into great detail about this. I just want you to know that this is a field of science where they study people's nonverbal behaviors and try to determine are they lying? Are they telling the truth? Are they being authentic? That type of thing. And you get a lot of these people that work for news agencies or work for interrogators or attorneys and that kind of thing that try to do this. And again, I'm not going to go into great detail about it. Turn signals, this is going to sound like really intuitive, but yielding a turn. So letting somebody in class, like you go like this, and then that means it's their turn to ask a question. We've all been trained to raise our hands when we want a turn, like in a classroom. You see these little kids here. We have to untrain our graduate students. We have these classes with our graduate students where sometimes we only have 7 people in a room and they're like, raising their hands, like, you don't need to do that. A finger or just start talking. Just let's talk to each other, that kind of thing. So that would be turn requesting. And then turn denying would be if we are talking and somebody tries to interrupt, and we might do something like, or we might close our eyes, like I'm talking and this person tries to interrupt and I just simply shut my eyes. That's sort of saying like, it's not your turn right now. So I had a client very early on in my career. I was in graduate school and in training, who would come in and I would go, how was your week? And she would just start going and going and going. And she'd flit over here and she'd flit over here. And I remember sitting in supervision with my professor and going, and he's going, you're not getting a word in wise. Like, how are you going to help this woman if you don't take control and you aren't able to get in the room and offer up something? Or even in the stuff that she was venting, she was flitting all over the place. So it was not organized enough to actually like, let's grab one thing here and let's just focus on this one thing in your life, this one example in your life, so that we could make some progress. So here's what my supervisor had me do. And keep in mind, we're videotaping this, or he's sitting behind the one-way mirror watching me. And I'm so flustered with this client. And I kind of didn't like her. Okay. So he has me go in, and the next session I sit her down and I had to say, before I'm going to ask how you're doing, before we start talking with one another, I'm going to let you know that I'm going to start doing this thing where if I feel like our conversation is going off target, getting on a tangent, I'm going to be, first of all, do this. It's like time out. But I'm going to need to let you know, I want you to stop talking. If I say like time out, like I would like a term, if you don't do that, I'm going to put my hand up and I'm going to say, this means stop talking. And I got to tell you, that I had to eat my Wheaties that morning. That felt so uncomfortable for me to do that intervention. It was so uncomfortable. I was like, she's going to hate me. She's going to think I'm mean, I'm rude. And it ended up being such a blessing in our therapeutic work. And what was really fascinating about it is a part of her flitting everywhere, like we weren't accomplishing anything because we couldn't come concrete to one example, was that most of what she was complaining about was problems with relationships with other people, because she was behaving that way with other people. She would visit a friend and she would download everything that was going on, but she wouldn't invite the friend, well, tell me how you're doing. She wouldn't do that. So she'd wear people out. She'd push people away. And it ended up working in therapy, but it actually ended up helping her well beyond the therapeutic relationship, because she realized that's how she was behaving with others. So very painful for me to do, but very effective. It was really good supervision advice for me. Paralinguistics, this is where, this is kind of the study of a person's voice level or volume. I've worked with some clients before, as an example, that are really struggling to be effective in their lives. And they come into therapy and they tell me, I'm having problems with my husband, and he doesn't like to listen to me. And it's one of those, like, just in listening how they're talking, it's like, oh my gosh, you sound like a doormat. Oh my gosh, you sound like somebody could just plow right over you. It's no wonder that there's problems with that kind of stuff. We pay attention to pitch and intonation, the rate of speech. I know when I worked in a hospital setting where I would do rounds in an emergency department, as people brought in for psychiatric emergencies, you could tell when a police officer or a family member was bringing in somebody with mania, because you could hear it in the level in which they were talking, and they were flipping around, and they were, and you're, I don't want to go to the hospital, I want to go party. You could just tell by listening to the rate of their speech. You're like, mania. And from an emergency department standpoint, usually that would require emergency medication to bring them down out of that mania. And then fluency. I've worked with some clients that are very articulate, and I've worked with clients that aren't very articulate, but paying attention to how fluent their speech is. Okay, proxemics. This is the study of measurable distances between people and how they interact. Boy, aren't we kind of learning this a little bit with everybody being on Zoom nowadays? So, like, let's say that I was teaching you and I'm way back in the room and I'm trying to teach you way back here. This would feel really uncomfortable and really ineffective. Imagine if I'm trying to teach you and I'm on Zoom and I'm like way up here in the camera. That would be really uncomfortable. The same thing exists for when we are interacting live with a patient or a client. We want to be appropriately close so that it feels intimate. We don't want to be so close that it's uncomfortable or we're touching them, and we don't want to be so far away that it feels like a non-human experience is going on. I'm real adamant about, I don't think that there should be a desk in between me and my clients. I think we should be sitting next to each other. I don't even do that with my students. If you could see my office at school, which you can't right now, I have my desk, and I don't have a desk between me and a student. I'm always interacting with my students beside. We know that dim lighting, it offers up, people disclose more personal information in dim lighting than in bright lighting. And when I think particularly in medical settings, you do not want to ask individuals, like, let's say you're inquiring about their sexual behavior because they've contracted an STD. You do not want to do that under bright lights, under interrogation, when they're in the paper suit. That's the kind of thing that you would bring somebody back to an office that's dimly lit with their clothing on, where they can feel like a human being, and say, I've got bad news, you've got this STD, and now we need to talk about who you've been with sexually and figure out what we're going to do to not only take care of you, but to help protect these partner or partners that you have had. Think about it like, let's say you want a hot date with your significant other, and because you might want to get some nookie that night, you would go ideally to a restaurant that had candlelight, so dim lighting, so where there's like lots of talking with one another to create that sense of intimacy. You would not go to McDonald's, as an example. We also, in proxemics, we kind of notice how people sit together, how if you're doing couples therapy, you can oftentimes tell how they come in and they sit down on the couch if things are going well. If they're going well with one another, they'll be facing one another, maybe even touching, maybe interacting. If things are going bad, they're oftentimes sitting, facing away from each other, not making eye contact, definitely not touching. So we pick up a lot of that. And then touch. I used to say in this class, it was my pet peeve that healthcare providers oftentimes did not offer up a introduction, a firm handshake, eye contact. And boy, coronavirus has changed things. I don't think we will ever be using that custom anymore of a nice strong handshake. But anyways, so we're going to have to figure out how we're going to express that level of, it's nice to meet you, let's work together, or whatnot, without that. Time, ideally, healthcare providers have to control the amount of time that they're working with individuals. And so an example would be the 50-minute therapist hour. Most therapists have an office where they can, there's a clock somewhere near where they're looking at their client, so they don't have to go, and interrupt the client talking, or they don't get their phone and interrupt their client talking. There's a way that they can see the time. And then they model this in TV all the time, and I hate it, where they've got the therapist, the person's our time is up. See you next week, or time is up. Let's schedule another appointment. I've got this whole thing that I do where I start kind of fidgeting, and I'll reach for a appointment card, and I reach for a pen, and it's just this sort of, it's a nonverbal, like, okay, they still could be talking with me, and we still could be wrapping stuff up, but I've got this little behavior that just starts to indicate our time's about up, without saying, because that sounds so rude. Our time is up. You don't get any more. You don't get another second. It's rude. Anyways, we also have to acknowledge cultural differences in time. I found it interesting. My parents, because they kind of rose from poverty and were kind of self-made in their professional lives, that they felt very, very strongly that not only do you arrive on time and express your professional behavior, and you arrive on time because that is respectful for other people, they trained me to arrive early. And what if there's traffic that day? What if you encounter an accident and you go early to absolutely prevent not being late? And then I have this friend who is late all the time. And I have to keep myself in check, because I find that it irritates the daylights out of me. And I just have to realize, hey, culturally, she was not raised by Peggy Marks like I was. And she did not pick up on this, like, this conveys professionalism and respect. Responding to clients' nonverbal. So I told you I pick on Obama down here. And he is either, if you look at this, some of you are going to get different vibes. He's either thinking and choosing his words very correctly. He's touching his face, which we're not supposed to do in a pandemic. Or a lot of people would take that he is about to be deceitful. Like the way he's got his finger placed, like he's going to say something that people want to hear, or he's actually going to be telling a non-truth. So different things that we could be picking up on that nonverbal. So we want to check for congruency between clients' verbals and nonverbals. We want to respond to incongruency. It was like when Christian, did the snowplow with the skiing, and he's like, I'm okay, and shaking his head no. It's like, okay, I'm going to pay attention to the shaking of the head. And then we look for changes across sessions as an example. A lot of times, like if I'm working with a depressed client, they're oftentimes very slow, not showing much affect early on in the therapy. And as they start lifting from their depression, they will oftentimes come in with more energy and more expression. You can sort of see it in their nonverbals. They're not feeling as depressed. We want to be very sensitive to our clients' nonverbals. We want to help them decode their nonverbals. So we're looking for that congruency. And then we want to sync. I have found, like, if I'm working with a client who's really depressed, they've got that psychomotor retardation, they don't have much affect, they look sad, they're doing a lot of crying, then I get real slow in my work with them. On the other hand, I love working with teenagers. Sometimes I have these teenagers that they're like, and boy, when I get in and I work with them, I'm like, it's not this like slow kind of, and I'm just like, like I would be with a depressed client. So we want to sync, we want to synchronize and be at their level. Okay, so I showed you lots of pictures of my kitties. We were up to 6 kitties from natural, and then we're down to 3 kitties from natural causes. So I was up to 6 kitties at one point in my household. Now we are down to 3 kitty cats. So I am that crazy cat lady, and I'm proud of it. But then we've also got Mr. Leo, who is my sweet dog. So now I've shared my pets with you. I am going to say goodbye. I hope you all enjoyed the social support lecture. I hope this is going to be very relevant for you all in your personal lives. I hope that this will be relevant for many of you in your future healthcare careers. If you are going into a healthcare career, remember this stuff. Remember how important it is. And then as you train, work on the training, because this is really good stuff to have these good communication skills with our patients or our clients. See y'all later.